The basic principles of pKa, absolutely, right? So looking at pKa, looking at pH, right? What does that tell us, essentially, right? Just remember that when the pH of a solution matches the pKa of the drug, it'll be in that 50-50 state where it's 50% ionized, 50% unionized, right? And remember, when things get into an acidic solution, they're more likely to pick up one of those protons, right? Because that's what makes something acidic, is having those extra hydrogen ions around, right? And so for a weak acid, as it gets into a more acidic solution, especially below its pKa, you're going to find it picks up more of those protons. It's going to be more in that uncharged state. And what does that do to its absorption? It's going to be more lipid soluble. It's going to have an easier time crossing those membranes, correct? Right. For a base in that same acidic solution, remember it goes from B to BH+, it's going to be picking up all those protons, it's going to be charged, it's going to have a harder time crossing those membranes. Okay? Makes sense so far? So imagine if I were to have a patient who is taking a weak acid like aspirin, and they were to consume it with something acidic like orange juice. What would that do to its absorption? Probably increase it, right? Because I'd be lowering the pH, and it would be more in that state where it's HA with no charge on it and have an easier time crossing over, right? Versus if I were to say take it with something like an alkaline solution, say like a tablet of sodium bicarbonate or something, right? Some baking soda. What is that going to do to its absorption? It'll decrease it, right? Because more of it's going to be an A- state because you've upped the pH. There's less hydrogen ions floating around, so thus it's going to be more in that A- state. Yes, sir.
So weak bases and weak acids, are they starting as unprotonated?
It's an equilibrium between the two, right? So it just depends on where the pH is of the solution that it's in. So some of it's going to be in the unprotonated state, some of it's going to be in the protonated state. It's just a matter of that balance, right? And that's what that Henderson-Hasselbalch equation was telling you, is what is that ratio between unprotonated to protonated? As you shift the pH, because the pKa of the drug never changes, right? That's just inherent to the chemical. As you change the pH of the solution, you'll change that balance from one to the other. And that then will affect how well it's going to get absorbed or not absorbed through these lipid membranes. But remember, what was the kind of the key takeaway from the whole thing? Like dissolves like. So if I put a weak acid into an acidic solution, it's easier to absorb. If I put a weak base into a basic solution, it has an easier time to absorb. The opposite is true as well, right?
So the pKa determines the strength of the acid or base?
I don't want to get into like strong versus weak acids, right? Because it's not really germane to the discussion, right? We kind of use weak acids as kind of just a general term, right? If I could go back to my chemistry days, I could probably tell the actual differences between the two, but it's not really important for our purposes here, right? Any other questions? Fantastic. Okay, so we have a test next week, right? It'll be very similar to the first one. It'll go over these concepts. Whatever we finish with today is going to be the end of the test material, right? So just FYI on that one. So I might not get through all the material, but just know that's where we're going to be ending, okay? So continuing on, right? We talked about absorption. We talked about distribution. Remember, volume of distribution being a very important factor here. Talking about what does it tell us?
How far the drug will go.
Yeah, where does it go? Does it like to stay in the blood supply? Does it like to go out into the tissues? Right, important concept. Remember how there's ways we could change that with things like serum proteins. If we were lacking albumin, how that can affect the volume of distribution. If we were dehydrated, how that can affect it. Just remember talking about that? So those are good concepts to remember, because I can say I have a patient who is taking a medication that is normally 98% bound to albumin. Now they're malnourished and their albumin stores have dropped by half. What does that do to the volume of distribution of that drug? It's going to increase it pretty significantly, right? So again, those are the kind of concepts I want you to get. There's not a lot of math I'll have you calculate, right? In fact, I need to look at the test, but I don't think there's any math on there. But the concepts there, the variables, if I modify the variables, how is that going to actually change the results, right? Again, think through conceptually, not necessarily figure out all the numbers, okay? That's where a lot of it will go to with the more lipophilic substances, but there's the muscle. I mean, you can find the blood-brain barrier crosses there into the CNS. Lots of places it could go to potentially. We just normally think about the adipose tissues being a big storage spot for a lot of medications potentially. Yep.
So if you have really skinny patient, for example, you have to consider the fact that the patient is skinny and the drug might not go as far as it normally would go.
That is a concern in some cases there. What I will tell you is much more common is we have patients on the opposite side, right? You have patients who are really morbidly obese, where you have drugs that are relatively hydrophilic. And so say, for instance, when I dose a medication, I'll dose it how many ever milligrams per kilogram, right? And so you normally take the patient's entire weight and factor that into it. Well, if they have a disproportionate amount of adipose tissue, and I'm dosing that for a hydrophilic medication, and I'm assuming that drug's going to distribute all the way throughout the adipose tissue, that may not be the case, right? That's a false assumption. And so by doing that, I could overdose the patient because they have way too much of it now in the bloodstream because that drug didn't go anywhere. Right? So how do I do that? How do you adjust that? So there's ways we can get around that, right? And something I'm not going to put on the test by any means, but we can do things like adjusted body weights, right? Everyone based on their height has an ideal body weight, right? Some of us may be under it, some may be over it, but there's an ideal body weight, and then based on where the patient's at and what their ideal is, you kind of come up with an adjusted number. So it's like a fudge factor essentially, so we don't end up overdosing some of our patients. Okay. Any other questions? Good. All right. So moving on, we talk about metabolism, right? So how do we actually break down medications within the body? Typically, our main function here is that we are trying to get things more water soluble. That is the main goal of most of the biochemical transformations that occur within the liver, right? Because the liver is going to be one of the main sites for drug metabolism. Why do I want it to be more water soluble? Because then they can stay in the bloodstream and they'll eventually get expelled from where? The kidneys are a big one. We'll also find the bile is another source for some drug elimination, but the kidneys are going to be one of the major ones there. So the more water soluble something is, the more likely it is to get filtered through the kidneys and actually get eliminated in the urine. Okay, so that's going to be one of the big takeaways from this. Is that's the main thing we're doing in the liver is trying to get things more water soluble for the most part, right? Now, you can find that in some cases we can actually not only deactivate medications, but we can activate them in the first place, right? So there's a concept called prodrug. Have I mentioned prodrugs before? Right, so prodrugs just means it is normally inactive, and that by going through this enzymatic process, now we have the active form of the drug itself, right? So that means that, as an example, the antihypertensive ACE inhibitors, right? Have you covered anything about the renin-angiotensin system yet? Anywhere? It's an important thing we'll talk about when we get to talking about antihypertensives and whatnot. But it's a system where you produce this really strong vasoconstrictor called angiotensin II, and we have drugs that can block that essentially. And so normally we would give a drug called enalapril orally, and then once it goes to the liver, it gets converted into enalaprilat, and then that's the active form of the drug. Now, remember what we said, if you give something IV, remember that first pass effect we talked about? We can actually get around that by giving something IV. And so in those cases, guess what I give, what version of that drug I give when I give it intravenously? I give the enalapril. I actually get the activated form already because I know I'm missing that first pass effect that normally would activate it, right? Codeine, we mentioned, turns into morphine. Some people are really good at converting that. Some people are not so much. And then I also mentioned that Vyvanse example as well. Did I talk about Vyvanse previously? A little bit, yeah. Remember, it was one where some people would abuse amphetamine drugs used for ADHD by crushing them and trying to snort them. Well, this one is inactive until it goes through the liver. So if I try to snort this medication, you don't get much of a high out of it. So this was actually designed as an abuse deterrent, but nowadays it's very popular just because it's a pretty good drug. And so you'll find a lot of patients will be on this, even if they don't have any history of substance abuse issues or anything like that. But again, it has to go through the liver. It's converted to dextroamphetamine, and that is the active form there, right? So, as I mentioned, we see a lot of metabolism happening within the liver, but other sites can be responsible for this as well. Some limited amounts of metabolism occur in the GI tract, the kidneys, the skin, and you're going to find that the enzymes are responsible here. There's a lot of different ones, right? We have a huge variety of enzymes in the liver that can metabolize these substances, but ultimately the goal is to make them more water soluble, right? So there's two main phases of reactions we'll talk about. There's phase 1 and there's phase 2 reactions, and I'll talk about how they kind of play along with one another. Phase 1 interactions are typically modifying the molecule to make them more water soluble, right? So they're usually uncovering something, they're removing something from the molecule, they're modifying it such that it can either be more water soluble to go directly to the kidneys, or getting it ready for what we call a phase 2 reaction, which I'll mention here in just a second. So these are typical reactions, things like oxidations, reductions, hydrolysis, things like that. Far and away the most prominent one we're going to talk about will be oxidation. I'll mention that in just a second, the particular system we're going to be looking at. Now, the one that we'll mention here as being the most clinically important is going to be the Cytochrome P450 system here. If you don't take away anything else out of this talk about metabolism, it is that the Cytochrome P450 system is super important in terms of drug therapy, and you're going to find this is one of the main sources for drug interactions you're going to run into. Either things that inhibit this system or things that induce the system. We'll look at some examples of that in just a little bit, but there's other ones as well, things like esterases, hydrolases, but again, the oxidation pathway through Cytochrome P450 is the most important one we'll talk about. Now, phase 2 reactions are typically going to be something where we're adding something onto the molecule that, again, will make it more water soluble. So I can conjugate something like a glucuronide molecule to it, glutathione, sulfate, whatever it is. I'm adding something onto the molecule to get it ready for elimination in the kidneys. Now, one thing that students get kind of tripped up on, they think that, okay, well, if it goes through phase 1, it has to go through phase 2, and then it gets eliminated. Not always, right? I'll show you an example here where it can go through just phase 1 reaction. It can go just through a phase 2 reaction. It can go through both in some cases. Oftentimes, drugs will have multiple metabolic pathways that will utilize both or just one of these. And I'll show you an example of what that looks like in just a second. But again, just know that this is not mutually exclusive. It doesn't have to be just one or the other. It can be both. Sometimes it is all of them, right? So just to give you an example, don't get too hung up on this slide here, but the main point I'm trying to get away with this is that, again, you're going to be introducing your medication here, and then some of them, once you have this initial phase 1 reaction occur here, you have a phase 1 metabolite, that can either go directly for excretion, right, itself, or it can potentially go through one of these phase 2 reactions here where it has had something added onto the molecule and then can be excreted from there. Right? It can be either or, right? It doesn't have to be necessarily 1 and then 2. It could be just 1, it could be just 2, it could be both. So the example I mentioned here is acetaminophen. Now this is really important for toxicologists. Why do you think that is? It's one of the most common overdoses you're going to run into, especially for intentional overdoses, especially for accidental overdoses. Why do you think that is? Tylenols is everywhere, right? Like, it's absolutely everywhere. You can go to Costco and get a 500-gallon drum of it for like $10, right? Like, you can get a lot of this stuff very easy, and it's very ubiquitous, which is why we care so much about it. But look at the different pathways here, and don't memorize this, but I'm just trying to illustrate the point here that there's a lot of different pathways for just one particular drug. So the parent compound acetaminophen here can, one, go through the sulfation pathway. So you add on a sulfate group. Is that a phase 1 or phase 2 reaction? It's a phase 2, right? Good. I can add on a glucuronide group. Is that a phase 1 or phase 2? It's a phase 2, right? Or potentially I can go through the cytochrome P450 2E1 enzyme. That's going to be a phase 1 reaction, right? Because I'm modifying, I'm oxidizing it, and then I'll actually end up forming this reactive intermediate. It's called NAPQI. This is actually the thing. And when you hear about Tylenol toxicity, what's the organ you think about it causing damage to? The liver. This is the thing that kills the liver, right? This is the thing that actually causes all the damage. Now, normally our bodies can deal with that and can detoxify it because it'll actually go through a glutathione conjugation, which is then a phase 2 reaction, right? Because I'm adding on the glutathione group, and now it's not toxic anymore. I can eliminate it through the kidneys, okay? However, what happens when you overdose on Tylenol? Well, you end up exhausting these pathways. You run out of glucuronide to add on. You run out of sulfates to add on, and thus you have a ton of this NAPQ being formed there, and that's why you get the toxicity, okay? But just know that you see there's different percentages it's going to go through. It can range, right? Again, this is it's more complex than just saying, okay, it goes through phase 1 or phase 2.
Does the body favor the phase 2 reactions, or does it just let it go?
Just depends on the substance, right? It just depends on what our body just naturally does to it. For acetaminophen, like you see, it does favor the phase 2 reactions, right? Because the majority of it's going to go through these 2 pathways. That small amount of it will go through the ZEP2E1 pathway. Yeah. But again, as I exhaust those other 2 pathways, then it tends to favor the cytochrome P451. Yep, that's where we run into problems. So anyway, as I mentioned, there's a lot of different processes that are out here. This is just kind of giving you some examples of what they look like in terms of the different ones that are available. Again, even things like, we have specific enzyme systems for things like alcohol dehydrogenase and aldehyde dehydrogenase. Now, is anyone familiar with certain people of certain ethnic backgrounds? They can't really drink a lot of alcohol because they get a lot of the flushing. Anyone familiar with that? Talk about like the Asian flush. That's actually an issue of actual pharmacogenetic differences in enzyme expression there. Alcohol is actually a 2-step metabolic pathway, right? There's an alcohol dehydrogenase that breaks it down into this product called acetaldehyde that then gets broken down by this aldehyde dehydrogenase. Well, people of certain ethnic backgrounds, certain Asian persuasions, as you might say, actually are lacking this aldehyde dehydrogenase. What does that mean? Well, they have all this acetaldehyde floating around, and that actually is an irritant, right? It actually causes a lot of flushing. It causes a lot of redness, a lot of itching, and things like that. And so that's why certain people do not handle alcohol very well, because they actually lack the enzyme to break down that byproduct, right? So there's a lot of differences. Some people express some of these enzymes very well, some of them will not. It just depends on a lot of factors here. And we'll get into some of those and their specifics as we get into, Pharm 1 and Pharm 2, talking about the individual drugs themselves, right? So again, we talked about first pass previously, saying that drugs get absorbed through the intestine. A little bit of metabolism happens there in the intestinal mucosa, but the majority of it's going to be through the liver and then get passed on through. Remember, some drugs cannot be given orally because the first pass effect is so extensive. Okay, some drugs have almost no first pass effect when they go through. That's why a lot of times when you're looking at drug dosing between IV to PO, right, so intravenous versus oral, they can vary so differently, right? So some of them will be one-to-one dosing. But you can't take that for granted. Some of them will have, say, for instance, something like propranolol, a beta blocker. Maybe I'm giving 160 milligrams of it orally, but I'm only maybe giving, say, 20 to 40 of it IV, right? So because of that, the doses can change very greatly depending on first pass effect, depending on the bioavailability, a lot of different factors there, okay? So don't always assume it's just a one-to-one conversion between IV to PO, because that can get you into a lot of trouble potentially. Now again, there's ways we can give medications via different routes to bypass this first pass effect. So again, imagine what are some other routes that maybe that could get around first pass. We said sublingual can do that. What else? IM, sub-Q, IV, anything else? Rectal, right? So imagine there's, I always go back to the recreational substances because I think it kind of sticks in your mind a little bit better. But what are some other ways to absorb alcohol than just taking orally? Yeah, so you ever heard like a vapor teeny? Like it's kind of a little bit of a fad there for a bit, where they would actually try to aerosolize alcohol, and then you could breathe it in, right? The lung is a very vascular sort of space there. You can absorb it very easily, right? That would bypass the first pass effect, and presumably you get more bang for your buck for a given amount of alcohol, right? There's been some cases as well. What other routes could you give alcohol potentially? There's rectal administration. Also, how about for females? Vaginal as well, right? So there were cases where you'd find these high school students who had taken tampons and soaked them in alcohol and inserted them, and then they were found passed out. The reason being, I know it sounds crazy, but like this is the stuff you have to be kind of familiar with and be aware of, because if you can anticipate some of this stuff, then you can kind of put two and two together, so to speak. The reason is that why alcohol, when given via the rectal or the vaginal route, bypasses first pass effect. So for a given amount of alcohol, you may think, I can handle a shot orally, no problem. Well, yeah, it's taking into account a lot of metabolism that happens. When given via these other routes, you get much more alcohol for a given amount, and thus they get much more toxic potentially, okay? So again, you gotta be careful when you're giving things via different routes, because you may find the bioavailability can be greatly different, right? Again, do not try any of these things I mentioned in class. They are highly not recommended, okay? I say that as my disclaimer so I don't get in trouble later on. So I told them not to do it, but anyway. So getting into the actual enzyme systems, again, I mentioned cytochrome P450 is the most important one we're going to be talking about here, right? Because this is responsible for the majority of drug metabolism in the liver, right? Almost probably over half the drugs you're going to be giving to patients will go through one of the cytochrome P450 enzymes. It's also responsible for a ton of the drug interactions you're going to run into, right? And so we'll get into show you some graphs, kind of breaking down the different, seeing which ones are used more often than others. But just know this is involved in a ton of drug interactions. You will need to be aware of these. And I'll mention specifically in Pharm 1 and 2, hey, this one is going to be a problem because if you mix this drug with this drug, this is an inhibitor, this is an inducer, it's going to cause this problem, right? And those are definitely testable questions, as we'll see later on. And there's more than 50 functionally active ones just in humans alone. Now, are you going to know all 50 of those? Probably not, but I want to focus on some of the more kind of high intensity ones, the ones you're going to run into very, very commonly, right? And anyway, looking at this, you can find that basically there's not just one CYP450 enzyme. There's a lot of different varieties that we'll run into, different isoenzymes that are responsible for different drug metabolism, right? So you're going to find that, say, 2D6 is good for certain types of drug metabolism, 3A4 is good for other types, and we'll learn about those, right? We'll learn about those specific instances as we go forward. And they get basically classified based on their amino acid sequence. So just to give you an idea how these get broken down, essentially a CYP enzyme name might be something like CYP2D6, right? That's just the enzyme name itself. How do you break that down? Well, the CYP is the cytochrome P450 system. So anytime you see CYP, you know it's going to be a cytochrome P450 enzyme. The 2 is part of the family name, so you can have things that are like 2B something or 2D something, but the 2 is going to be this family here. It's all based on the homology of the amino acid sequence. The D is a subfamily, and then the 6 is the individual enzyme. Okay, so in this case here, the enzyme itself is a CYP2D6 and is responsible for certain drug metabolism. I'll give you some more concrete examples here in a second. So, this is probably the hardest list to memorize for this class. So I'm just kidding. You don't have to memorize this. the point being is I want you to be aware of just how ubiquitous the system is and how it's going to affect almost, the majority of drugs you're going to be giving to patients here. So some things I want you to note here. One, the CYP enzyme name specifically is here. So things like 3A4, 2C9, etc. Those are individual isoenzymes. Okay. Now when I say substrate, what does that mean? These are the things that get metabolized by that particular enzyme, right? So for instance, 1A2, CYP1A2 will metabolize acetaminophen. Okay. It's a minor pathway, but it will do that. Here I have an inducer. What does inducing mean? I'm going to increase expression of the enzyme, meaning I have more of it around, meaning what does that do to my drug metabolism? It speeds it up, right? So it's going to be more likely to metabolize these drugs more quickly. What does that do to my drug levels? They're going to go down, right? Because the enzymes are more prevalent, more frequent, they're going to be metabolizing more quickly. The drug levels will go down, okay? This is a tough concept because you have to think about the seesaw sort of effect here, right? So the more enzyme I have, the less drug I'll have, because I always think about Pac-Man. When Pac-Man's kind of chomping the pellets, right? You're going to have more Pac-Man around chomping those pellets even more quickly, right? The board's going to clear a lot faster. On the other hand, we can have inhibitors that will impede the actions of the CYP enzyme, so they'll work less effectively. And what will that do to my drug levels? They'll increase, right? So if I have a CYP enzyme inhibitor on board, that will increase levels of the affected drugs. If I have an inducer on board, that's going to decrease levels of affected drugs. Okay? Potentially, right? So if you have an inhibitor, perhaps you may not get as much of the prodrug being converted over to the active forms, maybe less effective, right? That could be one case you might run into that. It's rare, but you may see that. So let me give you some examples here, right? So in just looking at the different the numbers of substrates for these particular enzymes, which one do you think is probably the most important one to know? 3A4, right? So if you need to take away just one CYP enzyme to know above all others, CYP3A4 is going to be the most common one you're going to run into. It's going to be the one with the biggest list of inhibitors, inducers, and it's just going to have the biggest number of substrates. So here's CYP3A4, that's the most common one you're going to run into. You need to know about that one. You should always perk your ears up for that, right? And again, you don't need to know all the drugs. We'll cover all of these as we go forward. Don't worry about that. So no CYP3A4. Just know that's going to be the most common one you're going to run into in terms of interactions, in terms of substrates. It's just going to be the most common. So imagine here, like for instance, I have a patient who is, say, taking, amiodarone, right? Amiodarone is an antiarrhythmic drug that we'll give for things like VFib and VTAC. Now, what would happen if I had an inducer on board, like, say, for instance, barbiturate, like phenobarbital, right? If I have an inducer on board, that will cause my amiodarone levels to go down, right? Because I have more of the enzyme around to break it down, right? Versus if I were to give something like diltiazem, which is another cardiac med, it will inhibit CYP3A4. What will that do to my amiodarone levels? Cause them to increase, right? Good. So you're starting to get the concept here is in terms of if I add an inhibitor on board, levels of the drugs tend to go up. If I add an inducer, they're going to go down. So a really good example of this is our grapefruit juice with our statins, right? So grapefruit juice is a very potent inhibitor of CYP3A4. Remember we talked about statins. Anyone know what we use those for? For cholesterol, right? So simvastatin, atorvastatin, rosuvastatin, some of those tend to be metabolized pretty extensively by CYP3A4. So if I have an older patient who's taking grapefruit juice, they drink that just because they like it, along with their simvastatin, that's going to cause levels of the simvastatin to do what? It's a CYP3A4 inhibitor. It's going to cause levels to jack up pretty high, and they can develop hepatotoxicity. They can develop severe muscle breakdown. Anyone know what the name for that is? Rhabdomyolysis, right? So you can have patients, you have someone who, say, a little bit older patient, is kind of a couch potato, and they call up and they're like, yeah, I'm taking my simvastatin, but I just feel like, I just ran a marathon, my muscles are all super sore, and I went to the bathroom, and my urine looked like it was like tea. It's a bad sign, right? It could be signs of muscle breakdown because of this interaction between these two, right? So you need to be cognizant of that and make sure you educate on those sorts of things, so that way they don't inadvertently have one of these problems, right? If you're to look at the breakdown, right, so we have our phase 1 reactions here versus phase 2, you find that CYP3A4, again, over 50% of those metabolisms are going to be through CYP3A4. So this is why this one's so important. Other ones that I would also kind of key in on and kind of make note of when you see it, things like CYP2D6. This is responsible for a lot of talk about TYP2D6 in terms of the heart and the head. So a lot of medications that affect both the heart and the brain, like a lot of psychotropic medications, tend to be through CYP2D6. Another one that's big is also going to be like 2C9, 2C19, things like that. Okay. So again, these are very common to have drug interactions here. You need to look this stuff up prior to giving a med, because again, are you going to know every single interaction that's out there? Very unlikely, right? Unless you're some kind of savant. I doubt you're going to know every single one of these, but you can always look stuff up, right? So always be careful whenever you're out on a new medication, because again, are you always going to be the only provider giving prescriptions to a patient? Now, a lot of times you're going to have 3, 4, 5 other providers, right? And they're all writing meds for the same patient. So you got to be careful and actually go through, do your good med history, and find those interactions, because they could be causing severe problems for your patient potentially, right? Okay. So as I mentioned, there's other places where you can have drug metabolism. The gastric acids can do this as well. When you think about things like, for instance, insulin, right? Insulin, how do we normally give insulin? Yeah, subcutaneously, right? Why don't we give it orally? Because the first pass effect, but insulin itself, what kind of molecule is it? Is it a protein? Yeah, it's a protein actually, right? So it's a protein itself. Well, what does our stomach like to break down? Proteins, right? Just like a juicy steak, insulin is a protein. So you find that a lot of protein-based medications we cannot give orally, because things like the gastric acids and digestive enzymes will just break it down, right? So we can't utilize it via those routes. You'll find a lot of medications we use for things like inflammatory diseases like rheumatoid arthritis. A lot of those are protein-based, and we have to give those via injectables too, right? Because we know the stomach's not a good route for that. Also think about things like the gut flora, right? When I say gut flora, what do I mean? Yeah, the normal bacteria that are growing in your GI tract, right? Well, that's responsible for a lot of the vitamin K that we actually can absorb, right? So one of the issues we run into is with the drug called warfarin. I mentioned that before. What does warfarin do? It's a blood thinner, right? So it's one of those things where it blocks the action of vitamin K. So say, for instance, I have a patient who's on warfarin and I give them an antibiotic. Now, do antibiotics know the difference between a pathogenic bacteria versus what's hitting around in my gut? Nope, it kills them all anyway, right? So you're going to find that you may wipe out some of that normal gut flora. That's why I see a lot of diarrhea and things like C. diff after you give antibiotics. And then all of a sudden you're not absorbing as much vitamin K. That makes the warfarin work that much better because there's less vitamin K to inhibit. And guess what? Now your patient's experiencing what? Bleeding, right? Having adverse effects because of an antibiotic regimen they're getting. So the cardiologist might have given them the warfarin, but they come to visit you because they have pneumonia. They get an antibiotic from you, and all of a sudden they start bleeding out. Right? So these are things you have to keep an eye on and consider. Yes, ma'am.
Does it work the opposite way? So if they take warfarin and they eat kale, will it inhibit the drug?
100%. Yeah. So anything, we'll talk all about warfarin later on, but yeah, so increased vitamin K intake will do the opposite effect and could cause, clots potentially. Yeah, warfarin is kind of a barrier. Nowadays we're getting away from that because we have newer drugs, but it's still used with some regularity. Yeah, we'll talk all about warfarin later. Don't you guys fret about that. Anywho, other metabolism factors to consider, things like liver disease. So you may have patients, especially older patients, people who are alcoholics, things like that, who tend to have depressed liver function. The worse the liver function is, the slower the metabolism will be potentially, right? So you always want to check up on if there's any changes in dosing based off of liver effects, right? So for instance, if you're doing your homework assignments and you're looking up to see well, how do I change my dosing if the liver's not working as well, right? That's a concern. You have to think about that. It could be anything. It could be viral induced, could be alcohol induced, could be anything that can inhibit the activity of the liver itself. Other things as well that can affect metabolism. Really anything that impedes the ability for blood to get to the liver is going to slow down slow down metabolism. Why do you think that is? Because if the drug never gets to the liver, it can't metabolize it, right? So if they slow down blood flow, it's never going to get there. So for instance, patients who have congestive heart failure, who have a lot of pulmonary or have a lot of venous backup, right? They're having a lot of edema. They're not getting a lot of fluid to the liver itself. That slows down metabolism. So as an example, I'm sure most people have heard of the drug lidocaine before. What do we use that for? The local anesthetic, right? It'll numb up areas wherever you apply it to. People probably got it at the dentist or something like that. Well, given to the heart via IV, you can actually use it as an antiarrhythmic. You can treat arrhythmias with it. But with patients who have congestive heart failure, because I know their metabolism is slowed down, I have to give half the normal dose I would for those patients there. That's just something you have to take into account when you're doing your dosing to make sure you don't give them too much, right? You see a lot of nasty toxicities from that. So just something to keep in mind, right? Other things as well, think about, what does metabolism do in a patient who has hypothyroidism? It's fast, slow?
slow.
Yeah, everything is slowed down, right? You know, if they have hyperthyroidism, that can increase metabolism. Genetic factors, like we mentioned, diet and environmental factors. We mentioned the grapefruit juice, but also anyone have any nice charcoal broiled foods on the 4th of July? It actually can induce and actually upregulate some of the hepatic enzymes you run into. So that can affect drug levels as well. Age and gender, anything affecting blood flow to the liver. So there's a lot of factors that go into it, and we'll talk about these and actually get into the specifics when we get into the individual drugs later on. Okay. So any questions on that? All right. So now, yes, ma'am.
So like as far as food and liquids and all that, do you recommend that your patient not take it at all, or just not take it at the same time you would take it?
Which one specifically?
So like, so say you take grapefruit juice because you know like elderly patients are fast.
Yeah.
So if you tell them don't take it with your medication, like have it like 4 hours later, or just don't take it.
Yeah, so that's one of those cases there where the effects are going to be a little bit more long-lasting than just separating out by a couple hours, right? So there's certain food-drug interactions you'll see where they say, okay, we'll take it 1 hour before or like 3 or 4 hours after, right? You can't really get around, right? Because that grapefruit juice activity is a little bit longer than that, you know, be more consistent. So in those cases, you do a couple of things, right? You can say, well, don't drink any more grapefruit juice. The patient may say, okay, I'm going to do that, or they may say, okay, I'm going to do that, and then not do it, right? That happens pretty commonly, right? It's that intelligent non-compliant sort of thing there. Or they may forget, or whatever the case may be, right? So what can I do instead? Well, potentially I give them a different medication that does not go through that same pathway. So a lot of patients you may find they would switch from something like simvastatin to something like rosuvastatin that does not go through 3A4, and then now you don't have to worry about it. But if I had a relatively young, healthy patient, you know, who has hypercholesterolemia, and I say, here you go, here's a statin, I'm pretty sure, you say, do you ever drink grapefruit juice? And they're like, no, that stuff's gross. Yeah, simvastatin's probably fine for them, right? So again, there's a lot of factors that go into it, right? Okay, getting into drug elimination. So we mentioned what's the main place you find most elimination of drugs? Yeah, the kidneys are going to be the big place, right? You know, the bile is also going to be another one, but the kidneys, for our purposes, is going to be the majority of it. And again, most drugs will tend to go through some form of metabolism and then get excreted through the kidneys. Some drugs may not undergo any metabolism, and they'll get excreted unchanged through the kidneys themselves. Okay, so again, it could be one, could be both. It just depends on the drug itself. Okay, other stuff will get sent out through the biliary tract and eliminated through the gastrointestinal tract through the feces. That's another way for certain drugs as well. Okay. As I mentioned, most drugs tend to be small enough where they get freely filtered by the glomerulus. Have you guys covered any kind of renal physiology? Kind of familiar with the nephron? Okay, well, I'm going to see if I can do a little bit of drawing here just to embarrass myself a little bit. So if you imagine, is at least familiar with the kidney, right? Just kind of what it looks like. A very poor kidney. But if you think about the functional unit of the kidney, it's going to be the nephron, right? So you kind of start off with this glomerulus. That's where all the filtration actually happens here. And then you have your first proximal convoluted tubule. You're going to have your loop of Henle. You have a distal convoluted tubule, and then eventually have the collecting duct, right? And this is where all the urine eventually goes. Okay. Anyway, most things tend to get freely filtered here of the glomerulus. That includes things like protein, glucose, all kinds of stuff, drugs as well, right? Through here, you may find that some of it's going to be reabsorbed, maybe secreted through the renal tubules, and then eventually gets eliminated through the urine here, right? And like we mentioned, aspirin, we talk about that example here where it can actually be reabsorbed depending on what the pH of the urine actually is, right? We talk about how by modifying that we can increase the elimination there. As I mentioned, charged molecules tend to not be reabsorbed very easily because they have a hard time getting across that renal tubule, right? Because again, it's a biologic membrane just like anything else. And urine pH range usually somewhere between 4.5 to 8, and it can range pretty greatly because the kidneys are one of the main organs responsible for helping to regulate acid-base status, right? The lungs are another really important one, but the kidneys are also going to be for more kind of long-term control of that, okay? So again, just know that most drugs get freely filtered. Whether or not they get reabsorbed or secreted is going to be kind of up for debate depending on the drug itself. Now, some drugs are actually too large, so they may not be able to be filtered very well, and so in that case there, that may kind of affect how long the drug will stick around for. But looking at this, as I mentioned, weak acids tend to be excreted faster in alkaline urine. So again, this is where we're utilizing the like dissolves like, and the opposite approach, saying that like, I guess you would say that the opposites are not going to dissolve very well, so that such that if I have an alkaline urine, acids get eliminated that much more quickly, right? That's why I talked about the aspirin example previously, where I can give sodium bicarb to increase the amount of aspirin that's in that positive charge state, and it gets eliminated through the urine there. Okay, but you can find that a lot of that trapping can happen anywhere else as well. So you can see things like vaginal secretions, breast milk. You can see it in prostatic secretions. Anything like that could be a site where drugs can be potentially trapped, depending on changes in that pH there, right? So again, I'm not going to belabor this point again, but remember that was where we're using sodium bicarb to ion trap aspirin in the renal tubule for elimination through the kidneys. If normally you would have to say a more acidic urine, say it's like 4.5 to 5, you tend to find that it would be reabsorbed very easily in those points there. Okay. So anyway, so when we're talking about drug elimination, we're talking about clearance, right? It's kind of another term for what we're going to be using to refer to this as. And basically, it's the amount of blood being cleared of a drug per unit of time. Usually can be quantified in terms of mLs per minute, so how fast we're clearing that blood of the medication there. And this is describing kind of all sources of elimination. We talked about renal being the most common one, but also, you know, looking at liver, biliary, and any other things. Maybe you off-gas a little bit of it in the lungs, you know, maybe some of it gets eliminated through the skin, who can say, right? But for the most part, you're going to find the kidneys are the main site of drug clearance, okay? So clearance itself is really important for determining drug concentrations. Why do you think that is? Because if I'm clearing it really quickly, my kidneys are working well, drug concentration should go down, right? Because I'm getting rid of it, right? If my kidneys are working poorly, drug concentration should go up, okay? So is there any way we can try to estimate what the renal function is to determine how well a patient might clear some of these drugs? This is where we're going to talk about creatinine, right? Creatinine clearance is what we're going to be calculating here. I'm not going to have you calculate on the test, but I want to illustrate to you the points that affect renal elimination, okay? So again, creatinine, where does it come from? Yeah, so it's a product of muscle breakdown, right? Just natural, normal muscle breakdown, right? So you're going to already find there's going to be some interpatient variability there. Who do you think makes more creatinine, more serum creatinine, a bodybuilder or an 80-year-old little old man? Maybe he's a bodybuilding little old man, who can say, but presumably the 20-year-old bodybuilders are going to probably have a little bit more creatinine in their blood just because they have more muscle mass, right? What about like an amputee? Right, a little less, right? So again, we'll talk about these considerations here, but creatinine, again, comes from the muscle itself. Now, you will find that creatinine is good as a marker for renal function because it doesn't really get reabsorbed or secreted from the kidneys. Once it gets filtered, it kind of gets passed out through the urine there. So the most accurate way to actually determine what a patient's creatinine clearance is would be to do what? Collect their urine for 24 hours and then determine how much they pass through there, and that would tell me the creatinine clearance. Is that super viable? Give a patient a big bucket, say, here, pee in this all day long, come back to me in 24 hours. They're probably not going to do that. So instead, what I can do is use a surrogate marker. I can use their serum creatinine in the blood as a determinant to say, okay, well, if they have a lot of serum creatinine around, if it's still floating around the blood, what does that tell me about their renal function? Probably not very good, right? Because they're not clearing it out the blood very well. If it's very low, then I know, okay, the kidneys are probably working pretty well, okay? And so, well, how do we actually determine what that's going to be? Well, we have calculations for that, right? We have different formulas that can help us out with this. And there's different ones for different patient populations. Cockcroft-Galt's a really good one for most drug dosing for normal adult sort of patients. Here's one called the MDRD that is good for older patients. We have ones that are good for pediatrics. They're normally including most of the same factors, and that's what I want you to focus in on is how do these factors change the renal function itself, okay? And so what I do here is I'll actually calculate what the patient's creatinine clearance is and then base my drug dosing off of that. Yes, ma'am?
You say creatinine is the
Doesn't get excreted. So it gets filtered through the glomerulus, but doesn't get excreted or reabsorbed in the tubules afterwards. Okay? So again, yeah, so whatever gets filtered gets eliminated essentially, right? It's kind of one of our best. There's other ones that we can use potentially, but creatinine is kind of our tried and true one. Okay? She's saying, so it was just a matter of clarifying that creatinine gets filtered through the glomerulus into the renal tubule, but it doesn't get reabsorbed or secreted. So that way, whatever gets filtered is what gets eliminated, essentially. Anyway, so let's look at the factors that go into determining a patient's renal function here, right? So the Cockcroft-Gault equations, again, I mentioned a very common one we use for most drug dosing for adult patients. And so you see the creatinine clearance is equal to, first factor here is 140 minus their age. So what do you think that does for creatinine clearance? The older the patient gets, overall creatinine clearance should go down, which makes sense, right? Because the patient's kidneys normally get better as they get older. It's like a fine wine. No, they peter out, right? They're going to get worse as time goes on. So that makes sense. So the older a patient is, presumably the worse their renal function is going to be. Okay, so that's one factor you want to consider there. The next one's going to be weight, right? Why do we consider their weight? Presumably the heavier they are, the more muscle they have, right? The more creatinine that they can produce. Is that always the case? No, like we mentioned, there's like severely obese patients who will throw this off very well. You may think, wow, this patient's got awesome renal function, when really they don't. It's just they have a lot of adipose tissue. That's again where we would adjust their body weight based on certain factors, which I'm not going to get into. But just know that in general, the more weight they have, generally the more muscle mass they should have, and that will factor into this equation as well. So the more muscle, that will also cause the creatinine clearance to go up in those cases there. So then we'll divide it by 72, which is just a constant factor there, times their serum creatinine. Now note this is in the denominator, so the higher their serum creatinine is, what does that do to their creatinine clearance? It's going to go down, right, because it's in the denominator. There's an inverse relationship. Just like we said, if the blood's not filtering, if it's not getting filtered very well, your serum creatinine should be high, right? Versus if it's going to be, the kidneys are working well, it should be clearing it pretty effectively, it's going to be low. So remember, there's an inverse relationship here between the serum creatinine and the creatinine clearance itself. And then finally, for this one in particular, you multiply by 0.85 if it's a female. Why do you think that is? Less muscle mass, usually on a pound per pound basis in general, right? So again, usually females tend to have a little bit more adipose tissue in general. Again, there are people who will go outside of this, but again, this was done way back in the day. So I think this was probably done back in the 50s or so, right? They take a bunch of people and then they generate a model based off of what their actual creatinine clearances are. And again, you have to think about what point in history this was done. Was it actually representative of a general population? Did they include different ethnicities? Hard to say, right? But again, this is kind of what we've been using for a good long time. It's kind of the best we got for now, okay? But you can find other ones here, like for instance, this MDRD one factored in if the patient was black, right? Because they found in their model that helped to fit it a little bit better, right, if you took that into account there. So different ones will use different factors there, but it just depends on that model. But again, know how the factors here, know how the variables, if they change, how that's going to be changing our calculations, right? So again, if the patient's older, creatinine clearance should go down, right? If the patient's creatinine is higher, renal function should be lower, right? So those are the things that I kind of want you to take away from that, right?
For the second equation, if the person's black and female, you could do both of those?
Yeah, you ended up multiplying by both of them, right? And again, that's just the model they came up with to fit the data that they had from that patient population, right? So it's hard to say, you know, if they'd done it, if you do it now in 2019, I bet this would actually change, right? Because again, our population does change as time goes on, so you may find them maybe a little different. But again, that's just what we've been using for a long time. So now again, what's another marker we could use to determine someone's renal function? Not just, you know, what their serum creatinine is. What else can I measure? What is the urine? I gave it away there, right? But so what do kidneys produce? Urine, and I actually monitor the urine output, right? That's actually another really good marker that I can use to determine how well the kidneys are functioning in terms of producing urine. The more urine they're producing, presumably, the better the kidneys are functioning there. So, especially for infants, we do that quite frequently. For other patients as well, we'll monitor their urine output. And again, that can be difficult to as well. That's usually more on the inpatient side of things. We'll be doing that, where you have kind of total control over the patient in terms of them being there in the hospital versus, you know, if they're out on the outpatient sort of setting. But for instance, we run into challenges with that all the time. You know, for an infant, it's pretty easy to get their urine output because what can I do for that? How can I measure their urine output? Yeah, I can weigh the wet diapers and can determine that. Certainly, if a patient has a Foley catheter in, I can just collect all the urine. That's really easy. But say, for instance, we have a lot of teenagers who are kind of chronic, have cystic fibrosis and things like that, who are chronically in the hospital. And you say, okay, well, I need you to pee in this urinal, and I need you to hold on to it until the nurse can measure it, and then you can dump it. Do you think teenagers always listen to what we say? Heck no, right? So again, oftentimes they'll have no accurate estimate of what their urine output is, and we have to rely on things like their creatinine clearance. So again, it depends on the patient population you're dealing with. Typically, a good serum creatinine is anywhere between 0.6 to 1.2. That's kind of a general number there. So like if you find like your dialysis patients have like a 3 or 4 or 5, like that's pretty typical for those type of patients there, right? What is dialysis? It's like an artificial kidney essentially, right? So again, a lot of patients who are chronically on dialysis, they'll go Monday, Wednesday, Fridays, usually for 4 hours. A lot of times in the ER, you'll find they'll come in like Sunday night or something where they miss their Friday session, and all of a sudden their creatinine is probably up in the 6s or somewhere like that. Yeah, this is a pretty common thing you run into. All right, what is GFR? Glomerular filtration rate. It's a hard word to say. Yeah, so basically creatinine clearance is kind of a surrogate for the GFR, right? So we kind of consider them to be sort of synonymous. It probably is a little different, but this is how we kind of figure it out, essentially. Yeah, good question, though. Typically, for normal creatinine clearances for patients, you'll find, average for males versus females, around 100 or so is typically pretty good. And you'll find when you're looking at your drug dosing for your assigned medications, some of them will have to be adjusted based off the renal function. It may say, hey, if the renal function is between 60 to 90, adjust it down to this. If it's between 30 to 50, adjust it down to this. If it's below 15, don't give it at all, or whatever the case may be, right? So again, you'll find that renal dose adjustment is super, super important, not only because, one, you have to look at the patient at baseline, but also is renal function completely static? Does it never change? Absolutely can change, right? And so for some patients, they can be very volatile in terms of their renal function, and it can go down precipitously depending on what's going on with the patient. You may have to adjust on the fly as well, right? So those are things we have to consider. Okay, so looking at clearance itself, we're going to find that clearance and our volume of distribution will determine what the half-life of the drug is. Let's say half-life, what does that mean? Time it takes for half of the drug to get eliminated from the body. Okay, that includes metabolism and the excretion. So the time it takes for half the drug to go away. Okay, so you can find that some drugs will have a very long half-life, some drugs will have a very short half-life, and depending on the patient's physiologic condition, you may find that this will change within that patient itself, depending on what's going on. So looking at this, you'll find that clearance will determine the amount of drug that can be eliminated per unit of time, but the volume of distribution will also tell us what kind of volume has to be cleared to get rid of that drug. So for something that has a low volume of distribution that's hanging out in the blood, you think you have an easier time getting cleared or a harder time? Easier, because it's right there in the blood. It gets filtered through the glomerulus, and then you're good to go, right? Things that have a high volume of distribution that's sitting out in the fat and the muscle, it's a much larger volume you'd have to clear. It's going to take a little bit longer. So you can already see that something with a high volume of distribution potentially has a longer half-life than something that, say, has a low volume of distribution, right? We'll get into the factors here in a second to look at that. But basically, this is really, really important to consider both the clearance and the volume of distribution, because that tells us the half-life. And then that will eventually tell us about the steady state plasma level. Now, when I say steady state, does anyone know what that means? Essentially what it means is the amount of drug I'm putting into the patient for a given period of time is the same amount of drug I'm getting out of the patient during that period of time. So say, for instance, I'm dosing a drug 500 milligrams every 24 hours. Once they're at steady state, every 500 milligrams I'm putting in, for that 24-hour period, they should be having 500 milligrams coming out. And we'll get some graphs on what that looks like in a second, but that's really important because that will determine what our steady state plasma concentration is. And remember, why do we look at plasma concentrations? Why do we care about that? So it shows us that we're getting high enough to get to the therapeutic effect, but not so high that we're getting to toxic effects, right? We talked about therapeutic drug monitoring and that narrow therapeutic index. Sometimes it's really important we look at that sort of stuff, and this is what goes into it, the clearance and the volume of distribution. Again, I'll give you lots of examples of this in just a moment. But let's do a 10-minute break. We'll come back, and we will continue on talking about clearance. All right, just to clarify for the assignment, I just want to make sure people are aware. So like when you search up to date, right? So I went to the AHU. I'm still used to saying ADU. I apologize if I get that wrong for the rest of the time. But AHU is just harder to say anyway, right? It just doesn't roll off the tongue. Anywho. Looking at this, so I went to the website, the library website, got to up to date, right? And I just typed in a drug that none of you have because I don't want you to get any easy answers, right? But basically, what you see here is I looked up cefepime, right? So it's a cephalosporin antibiotic. You get a bunch of topics here. The thing you want to focus on is the drug information, right? This is what takes you to Lexicomp. And there, from here, you can get all the information you need, right? So for instance, if I want to go to find the mechanism of action, like that'll be here. Sometimes it's not listed alphabetically, which is annoying. You find the mechanism. Here are all my pharmacokinetics and dynamics. Now, again, sometimes you're going to find that your drugs don't undergo a lot of hepatic metabolism. That's okay. Just state that, right? You just state that you've looked it up. You said there's nothing listed, right? That's not a problem. I didn't pick these so that you would have, a very obvious answer every single time. Because, again, in medicine, there's not a lot of obvious answers a lot of the time. But if you look at this one, minimally hepatic. Actually mostly gets eliminated renally. So that's one of those things where I would say, okay, well, I looked it up and I didn't find any enzyme systems. It's not really eliminated through the liver. That's a fine answer, okay? I don't want people to stress out too much, right? But again, Lexicomp through up to date is going to give you most of the information you need. So you really don't need to venture too far out from there. If you want to, that's okay, but look for reputable sites. If it's like druginfo.ru or something like that. Maybe not super reputable, or CZ, just go with your .coms or .orgs or .govs. Usually, what did you say? PubMed's a very good one. Yes, absolutely. PubMed, anything like NIH or NLM, things like that are good. I try and Wikipedia actually probably has a lot of really accurate information, but I try not to go with Wikipedia just because there could be, but actually Wikipedia's pretty good. Like, I hate to tell you, but actually it's pretty good because they're editing. I mean, maybe not 10 years ago, but like their editing system is such that it's generally pretty good. But now, if you ever cite Wikipedia on one of my assignments or anything in school, I mean, you'll get the slap down, but you can at least use it as a jumping off point. You can at least look at it and at least get some starter points. Anywho, okay. So any questions on anything we covered so far? I don't see any questions on the sticky board, but remember that's always available to you should you ever need it. Okay, so we're talking about clearance here, right? So we're talking about how we actually eliminate drugs from the body. There's a concept here, one called first order and then zero order elimination. Okay, most drugs you're going to run into follow this what we call first order elimination. Okay, what this means is that when a drug is getting metabolized and excreted from the body, it's basically meaning that for a given period of time, say for 1 hour, you're going to be getting the same percentage of drug eliminated for that same hour. So it doesn't matter if it's hour 1 or hour 10. If it's 15% per hour, you're always going to be getting 15% of that drug being eliminated. Okay. That also means that the higher the concentration is in the body, if I give a bigger dose, guess what? I'm metabolizing and eliminating more drug. If it's a very low concentration in the body, then I'm metabolizing that much less, but it's always 15%, right? It's always going to be that same percentage, right? The converse to that is going to be the zero order elimination. Basically, this is going to be when enzymes get saturated or certain carriers get saturated to a point where it doesn't matter what the concentration is in the body, I'm always going to metabolize and eliminate the same amount of drug per unit of time, right? So that's the big difference between these two. One's the same percentage, the other one's going to be the same amount, right? Just baseline amount. So I give you the example of ethanol, right? Ethanol typically follows zero order kinetics, meaning that people who have a alcohol level of say 80 milligrams per deciliter, they may roughly estimate or eliminate 20 milligrams per deciliter per hour on average. So if their level is 80, how long would it take them to get to a level 0? 4 hours, right? Because you do first hour is 20 milligrams per deciliter, the next hour 20 milligrams per deciliter. I'll show you some graphs of what this looks like. But you're going to find that most drugs do not follow zero order. Most of them are going to follow first order. Okay, just as an FYI. That's why they say you roughly estimate or you roughly metabolize 1 drink per hour. That's that 20 milligrams per deciliter. If you were to look at the graphs of a zero order versus first order kinetics here, you're going to find that again. Looking at this, it's going to be for zero order the same amount of drug per unit of time, right? You can't speed this process up. You can't really slow it down. It's basically just going to be the same amount of drug per unit of time. For first order kinetics, if you notice here, the first bit of time, what do you notice about the steepness of this curve here? Pretty steep as compared to a little bit later on, right? So again, it's always the same percentage of drug, but it's going to be metabolized much more drug during that first hour than it would be, say, hour 10, just because there's less drug around, okay? Again, I'll give you some more examples of what this looks like in just a little bit, because sometimes this concept can be a little tough for people to get there. And so essentially, looking at first order kinetics, which we're going to assume most drugs are going to follow this, right, unless otherwise specified, is that essentially how we determine our clearance is going to be the rate of drug in, right, so the rate of administration divided by the drug concentration itself, okay? What I can turn this into is that, well, do I give every single drug via continuous IV infusion? Very rarely do you do that because, again, just logistically, it's pretty difficult, right? So what I convert this rate into is going to be the dose and my interval. When I say interval, what does that mean? Kind of the time between doses, right? So again, it could be Q24 hours, it could be Q6 hours, it could be Q12 hours. What does Q mean? Every, right? So it could be any one of those, right? So I can change what the interval is, and I can change what the dose I'm administering to the patient is, right? So that's the rate and amount of drug coming into the patient, okay? And then divided by that drug concentration will give me basically what my clearance is, okay? So what does that mean? So it means if I give a bigger dose, what does that do to my clearance? It'll increase, right? So because again, it's proportional. So as I'm adding more drug into the system, you're going to be metabolizing more of it because it's that constant percentage per unit of time, okay? The reason why I'm kind of illustrating or kind of belaboring these points here because this is going to directly impact our half-life and how we actually dose our medications, as we'll see in just a little bit. Now, presumably, the concentration of the drug is higher. That means I'm not really eliminating it very quickly. What does that mean in my clearance? What does that do? it's going to decrease it, right? Versus if my clearance is very good, that drug concentration should be relatively low, right? Because I'm getting rid of it that much quicker, okay? And again, there's a proportional relationship between the drug concentration to the amount of drug cleared per unit of time. So the more drug that's present, the more of it's going to get eliminated. It's always the same percentage. So to give you an example of what this looks like, say for instance I were to give 1,000 milligrams of a drug via intravenous injection, right? So I just give an IV push. It's all in the body right this second, okay? So right now I'm at time 0. And let's say per hour I'm metabolizing 15% of that drug, okay? So that means that during the first hour, I metabolize 15% of 1,000, which is 150 milligrams gets eliminated, right? So now I have 850 milligrams left over. Now for the next hour, I'm metabolizing another 15%. And then the next hour, another 15%, and 15%, and 15%. So what do you notice about the amount of drug being eliminated per hour? It's decreasing, right? It's always 15% though. It's just a matter of how much drug is actually left in the body itself. That make sense? And if I give, say, for instance, 2,000 milligrams instead, how much would be metabolized that first hour? It'd just be double that, right? It'd be 300 milligrams during that first hour. Okay. So again, it's always going to be related to the amount of drug I'm putting in. You're always going to get that same percentage of drug being metabolized per hour. Okay. If you were to look at this, you can actually see, if you were to graph it out, you can actually get what your half-lives are going to be here, right? So again, during that first half-life, you get 50% of the drug being metabolized. During the next half-life, it's again another 50%, 50%, 50%, right? All the way down to where you have basically no drug left over, okay? So that means it doesn't matter if I give a bigger dose. It doesn't really change the half-life, really, because I'm going to be metabolizing that much more drug during that first initial period, right? If I give a smaller dose, it doesn't really change the half-life. The half-life remains relatively constant, regardless of the dose I'm administering, in first-order kinetics, okay? Everyone with me so far? Okay. Now again, compare that to a zero-order kinetics, right? We mentioned the alcohol example where you're doing 20 milligrams per deciliter per hour. So if I have someone who ingests a ton of alcohol, it's going to take them a really long time because there's not really a half-life associated with that because they're always metabolizing just at 20 milligrams per deciliter, 1 drink per hour. So if you drink 10 drinks, it's going to take you 10 hours versus if it was first-order kinetics, whatever the half-life would be, half of that alcohol ought to be gone in the first round, right? You're very rude, but they heard alcohol and they're like, oh, where's that? Anywho, so how do we kind of get a little bit deeper into this? Well, we have this constant called Ke, right? This is basically the elimination constant that we use to determine essentially what percentage of drug is getting metabolized per that unit of time, right? So again, when I said 15% in that example before, that was the Ke for that particular drug that I just had made up, okay? Now again, I'm going to get a little in the weeds here, then I'm going to bring you right back out so that way it kind of makes conceptual sense, so don't get too lost with me just yet, okay? Essentially what this is meaning, and I'll tell you why we do this and how we actually use this clinically, is basically if you were to look at the log of the concentration of drug versus time, by taking the slope of that line, you could figure out how quickly you're metabolizing that drug. So a drug that gets metabolized very quickly would have a pretty steep line, would have a very steep slope, versus something that gets metabolized more slowly would have a very shallow slope, okay? So basically how we determine that Ke is actually looking at the peak versus the trough of that drug for a given dose. When I say peak, what does that mean? The highest concentration you get versus the trough being the lowest concentration, and then I look at the change in time. So by looking at that difference between the peak and the trough, I can determine how quickly we're metabolizing that drug, okay? To put it another way, I could say that Ke is basically based off the clearance divided by the volume distribution, right? So now I'm bringing it back to something we already covered. I mentioned clearance. If clearance goes up, what does that mean about that percentage of drug I'm metabolizing? It goes up as well, right? So again, if I'm clearing it faster, that makes sense. You're getting rid of more drug. The higher percentage of drug you're getting rid of, okay? What do we say about volume of distribution? The higher it is, what does that do to that percentage? It goes down, right? This is inversely proportional because more of it's just hanging out in the tissue. It's not there to get eliminated through the kidneys, right? If I had a lower volume of distribution, what does that do to my Ke? It gets bigger, right? Now you're starting to see how these factors come into play here. And so again, looking at the Ke, I'm going to factor this into actually how I get my half-life for the drug. So as I mentioned, the half-life is the time it takes to get for the concentration to drop by 50%, okay? And so, for instance, if I have a drug at, say, 4 p.m. that has a concentration of 20 micrograms per ml, the concentration at 8 p.m. is 10 micrograms per ml. What's my half-life? 4 hours, right? That's pretty easy, right? It'd be nice if I get 2 concentrations and just figure that out at the exact moment of the half-life. But again, do we frequently do that in the real world? Not really, right? But oftentimes, in order to determine what a patient's half-life is, we'll measure 2 random levels of the drug, and then we can use math, right? You can figure out that KE and to determine what that patient's half-life is. Now, what if, for instance, we have drug B with a concentration of 40 micrograms per ml at 8 a.m., and then now it's 4 p.m., and the concentration is 10 micrograms per ml. What's the half-life? Is it 8? It's actually 4, right? So look at this, right? 8 hours have passed. How many half-lives have occurred here? 2, right? Because again, the initial half-life, 40 to 20, and then 20 to 10, right? So again, it's still 4-hour half-life. It's just that as you go on, you're metabolizing less drug because there's less drug there to be metabolized, right? Remember with me so far? I'll give you lots more examples of this. So again, looking at that, you see that, again, 50% every time, even though the total amount left over it gets incrementally smaller, it's always that same percentage of drug. The half-life is going to be relatively constant here, right? Unless I change the clearance or if I change the volume of distribution. I'll tell you when that kind of occurs. Now, half-life can be extremely variable depending on the drug that you're dealing with. So as an example, adenosine. Anyone ever given adenosine before? Emergency medical people? No, you never did. So if someone has SVT or supraventricular tachycardia, we can give adenosine, and that will basically stop the heart for a second and then allow it to restart normal sinus rhythm again. It has a half-life of less than 10 seconds. That means in 10 seconds or so, half the drug is already eliminated, right? Very, very fast half-life. On the other hand, say we had a patient who we're giving amiodarone to, which is another antiarrhythmic, has a half-life of roughly 26 to 107 days. It can be extremely variable, right? It takes almost a third of a year just to eliminate 50% of that drug. Okay? So clinically, what does that matter for us? Well, it depends. I mean, we may change our dosing pretty drastically depending on kind of what the half-life is, what kind of levels we're shooting for in that patient there, right? So again, it can be widely variable depending on the drug you're dealing with. So how do we calculate half-life? Well, essentially what we can do, and you don't have to worry about this 0.693 number. Again, I want you to know what the variables are doing here, right? I want you to know how the variables will have an effect on the outcomes. And so normally what we do is if we know what the KE is, we can just take the KE and have 0.693 divided by that. Alternatively, though, let's sub in what other variables we know that makes up KE. And because we know KE equals clearance over volume of distribution, by subbing that in, that basically means that the half-life equals this 0.693 times volume of distribution divided by clearance. Before your brains explode, let me illustrate what that means, though, right? Don't worry about the 0.693. That's irrelevant to our discussion. What does matter, though, is that what happens to the half-life if I increase the volume of distribution of that drug? It gets longer, right? It takes longer to metabolize 50% of that drug. If I decrease my clearance, what does that do to my half-life? It gets longer, right? Because clearance goes down because it's in the denominator. Half-life gets bigger, right? So it takes longer to get rid of that drug. Everyone with me? On the flip side, if I decrease my volume of distribution, what happens to my half-life? It gets shorter, right? I have a easier time getting rid of that drug because more of it's in that central circulation to be filtered by the kidneys, right? If my clearance goes up, what does that do to my half-life? Shortens it, right? So again, understanding how clearance and volume of distribution have a factor on the half-life, how it's going to change there. Because depending on what the half-life of the drug is, you may change a drug dosing, say, from every 12 hours to every 24 hours. Or I may have to give it every 48 hours. I'll give you a really good example. When we have a lot of NICU kiddos that get transferred to us at Nemours, right? We don't have any actual people giving birth there, but we get a lot of sick kiddos coming into us. We get a lot of premature babies coming in. Well, premature babies, do you think their kidneys are working as good as, say, a full-term baby? Typically no, right? So potentially some of the antibiotics we have to give them, depending on what their gestational age is, we may have to give the drug every 24 hours, every 36 hours, or every 48 hours. Because we know that their clearance is not going to be as good when they're more premature, we have to give the drug less often because the half-life is longer, right? Again, this is the clinical application of this stuff, how we can actually, this goes into the dosing that we're giving these patients here, right? Okay, so as I mentioned, the larger the volume of distribution is, the bigger the half-life, the longer it's going to take to get rid of that drug. A smaller clearance will have the same effect there, right? So keep these proportions in mind. Remember how one's going to affect the other. And it kind of makes sense when you think through it. Okay, if I'm not clearing as much drug, it takes longer to do so. The half-life is longer, right? So keep the relationships in mind. That's the big feature here. Because am I going to actually have to calculate based off the KE what a patient's half-life is for a particular drug? No. I may give you random concentrations and I say, well, figure out what the half-life is based off of that. That's pretty easy, right? I'll give you some examples of that. But again, the math is not so important, but the relationships is, okay? Anyway, so what is steady state, right? Steady state is basically going to be that time period where, or that point where the amount of drug I'm putting into the system is proportional to the amount of drug getting out of the system here, okay? And so basically what this means is that if I were to give a drug via continuous infusion, say I was giving this drug via continuous infusion IV, you'd find that the plasma level would be a flat line. It would not change whatsoever because the amount I'm putting in is the same as getting eliminated, okay? I'll show you some graphs of that in a second here. But I mentioned most times we don't give drugs via continuous infusion because it's not very practical. So I'll show you some ways to get around that. But basically, what you're looking at is the average concentration at a steady state is equal to the dose I'm administering divided by the clearance and the dosing interval that I'm giving the drug at. You know, I'll show you how this has an impact in just a little bit. But point being is, and one handy tip to remember is it takes roughly 4 to 5 half-lives to get to steady state. Okay, it's a good number to remember, 4 to 5 half-lives or so. So again, what does this mean here? So looking at the average steady state concentration here, what effect does the dose have on the steady state concentration? If I give a bigger dose, say I change a patient from, say, for instance, giving 250 milligrams every 12 hours to 500 milligrams every 12 hours, what does that do to my steady state concentration? Logically, it's going to go up, right? Because again, I'm giving more drugs, my concentration on average should go up as well. Okay. What do you think the effect of increasing the dosing interval would have on my steady state concentration? So say, for instance, I was giving 250 milligrams every 12 hours, and now I'm giving every 24 hours. It actually decreases, right? Because this will go up from 12 to 24. That's going to cause my steady state level to go down because now I'm giving the body more time to get rid of that drug before I give another dose, right? I could also do the flip side of that. I could actually give it more frequently. So I give a drug, say, from every 12 to every 6 hours. And that will cause my steady state concentration to do what? It's going to go up, right? These graphs will make a little bit more sense of this in just a minute here. But again, just remember that it's roughly 4 to 5 half-lives to get to that steady state time frame. So again, looking at this, and I apologize, yellow is probably not too good to see here. Let me see if I can draw on something else. You kind of get the point. But anyway, so looking at this, you can find that the average steady state concentration is what we're going to achieve eventually. But let's say I'm going to give this via continuous infusion. This red line is going to be the drug I'm giving. Notice the body's building up levels. It takes some time, and then eventually, once I get to that point here, I'm just going to stay at that level, right? Because this is going to be the same amount of drug I'm putting into the system as I'm getting out of the system, right? So this is my average steady state concentration if I were to give a continuous infusion of a medication. And then what happens when I stop the drug? Well, then it's going to go back down, right? I'll undergo normal elimination. I'm not putting any more drug into the system at that point. But again, if I were to change the dose, say I were to increase the dose, what happens to my CSS? It's going to go up here, right? If I were to say to decrease the dose, it's going to go down. I can't really change the interval here because I'm actually giving it continuously, but I'll show you what that looks like in a second. So looking at, say I was giving intermittent doses, right? Intermittent just means what? Every once in a while, right? It's on a schedule, but it's not continuous. You can see here that by giving a dose, you'll find that the level will go up, and then you start to have metabolism and elimination of the drug, right? And then I give another dose. Then I give another dose and another dose, and you'll find that eventually you'll get to this point where the average concentration, not the actual concentration every single minute of the day, but the average will be at that steady state level, okay? Now this blue line would be if I was giving it via continuous infusion. The red line is if I was using intermittent dosing. But you can find here that the average is what we're shooting for here, right? The same average is obtained even though I'm giving the drug intermittently, all right? You get fluctuations there, right? You get peaks and troughs, but on average you get the same steady state concentration, okay? Now this is where I could actually modify. If I were to say give this less frequently, what do you think my steady state concentration would do? Actually would go down, right? Because I'm giving the body more time to metabolize. So for instance, if I were to do that, you may find that instead of, say, stopping here, the level will go down, say, to here, and then I give another dose, and then another dose, another dose. And you may find the steady state concentration may only be like right around there, right? So again, that would be if I was giving it less frequently, potentially. Okay. This is another good graph to show you the example here. So there's several ways you can dose a medication, right? There's a million different ways you could do it, but potentially, let's look at 3 different ways we could do this. So this black line here is going to be if I was to give the drug via continuous infusion. This light gray line is going to be if I was to give it a smaller dose but more frequently. And then this other line here is going to be if I was giving a larger dose but less frequently. Okay. So what do you kind of notice about this right off the bat? Yeah, so the average steady state concentration is identical between all three dosing strategies, right? So what are the downsides of using that continuous infusion? It's not practical, right? Like, you're tying up an IV line and, you have to worry about the drug runs out and you have to get another bag already ready to go. And it's not super practical, right? So you don't do this frequently. What are some of the problems of, say, giving the really big dose, but I'm giving it less frequently? Higher peaks and lower troughs. Why might that be a problem? Yeah, so at the trough, you may find the drug's less effective, right? You may not be getting the efficacy you're looking for. What's the problem with giving these high peaks? You might see toxicity, right? So, okay, well, maybe that's not the best dosing strategy. What if I were to give it, say, more frequently but at a smaller dose? Sometimes you'll stay within that acceptable window a little bit more frequently, right? What's the benefit of giving less frequent doses? Better compliance, absolutely. So if I can give a drug every 24 hours, that's more likely to be compliant than if it's every 12 or every 6, right? Versus this might be more difficult from just a logistical standpoint. So you can see that it doesn't matter. I can modify the dose and the interval together to get the same average steady state concentration, but what really matters is how much vacillation is okay there, right? You have to kind of walk this line between convenience versus, can I handle high peaks and low troughs, okay? Certain antibiotics I have to give every 6 hours because if I don't, you're going to find the levels will get so low that the bacteria can continue to grow, right? Something I can just give one time a day and it's totally fine. A really high concentration. We'll get into those specific examples, but just know that doesn't matter the dosing strategy, I can still get to the same average steady state, okay? I can just give you, this kind of shows the same thing here. And remember that those single doses, what it would look like if I just gave one single fixed dose, but by giving doses, they stack on top of another, because again, you're not metabolizing, getting rid of all that drug by the end of that first dose, but by having them stack on top of each other, that's when you eventually get to that steady state. Again, that's 4 to 5 half-lives or so. Now, what do you think would happen if I were to say I was measuring the levels of a drug and I was using that to adjust my doses? And what would happen if I were to say get a level just based off the first dose here? And it looks like, oh, it looks way too low. Is that an accurate level? No, because I didn't wait to steady state. I didn't wait till they actually got to this point where they were equaling the amount of drug heading out. Is that what's coming in? And so this is a frequent issue we run into where people will get levels too soon and say, oh, the level's too low, not realizing they're not at steady state. And then what do you think they would do instinctively? Increase the dose. Now when you get to a new steady state, guess what? It's too much, right? Now you're going to find that they're having toxicity from that, potentially, right? So again, this is a very important concept to understand, like why we dose drugs the way we do. It's because a lot of these factors go into the kinetics of it, right? Okay, so another factor we can do, so what if we wanted to get to steady state really quick without having to wait for 4 or 5 half-lives? Because we looked at, amiodarone, right? So let's go on the low side, say it was 20 days for a half-life. How long would it take to get to steady state? 80 to 100 days. So if they're having a life-threatening ventricular arrhythmia, do I have 80 to 100 days to treat that patient? No, they're going to be dead right now if I don't do anything, right? So what can I do to get around that? Well, I can give a large bolus of the drug, a large amount of drug right off the bat to get them up to steady state, and then supplement that with what we call maintenance doses. That first big bolus dose is called a loading dose, okay? So you give them a loading dose to get them up to the steady state, and then you give them supplemental doses to keep them there. Okay, so as an example, if you were to look at the red line here is what would be the loading dose, and then the blue line is going to be the continuous infusion we give afterwards. You give a really big bolus dose up front to achieve this level here, this black line, but as that is being metabolized and eliminated, what do you notice about the blue line? Blue line's picking up the slack such that the level never really changes. Okay, so we call a loading dose. So if anyone's familiar with the drug Zithromax or azithromycin, Z-Pak, right? Has anyone ever taken that before? The first day you take how many pills? You take 2, and then after that you take how many? Take 1. Why is that? Well, the first dose is a loading dose, right? It gets you up to higher levels up front, and then you can take those 1 tablets a day afterwards to keep you at that higher level. Okay.
So will that be the same thing with like a metabolized pack where you 6 one day and then 5?
That's different. That's actually a taper built into it, so that's trying to prevent adrenal insufficiency. That's a different subject. We'll get into that, but no, it's a different concept essentially. Yeah, good question though. Right, so as an example with like lidocaine, if I was having a patient in VFib, I would go ahead and give them a bolus of 1 milligram per kilo up front via IV push, and then I follow it up with an infusion, say 20 to 50 mics per kilo per minute afterwards. The infusion keeps them at steady state. The bolus got them up to that loading dose, got them to that steady state in the first place. Okay. Again, zithromycin is another example of that. Okay. And again, the maintenance dosing is just what's keeping us there. Now, sometimes, like in the lidocaine example, you follow it up with a continuous infusion. That's not frequently done. Azithromycin is more common, where you hit them with a big dose up front, and then the subsequent doses are going to be those maintenance doses that keep them at that steady state. That will be more intermittent. But just remember that based on the dosing interval, the clearance, and the average steady state concentration I'm shooting for, this helps me to determine what my dose is going to be, right? So if I'm modifying it as other variables, it will tell me basically what kind of dose I need to give in order to achieve that maintenance dosing, right? To keep that steady state concentration where I want it to be, right? And just an example of looking at maintenance dosing, here's a drug called clopidogrel. It's something we give in patients who have had a heart attack and they're getting stents placed or something like that. It's an antiplatelet drug. And basically they end up getting a few days of loading doses up front, and then they end up getting maintenance doses afterwards, and it keeps them at this nice steady state concentration here. Yes, ma'am?
So would you say that loading doses are seen more frequently, like in other situations?
It depends on the drug. Like sometimes it doesn't really matter if it's, usually it's for things that have like a longer half-life. You end up seeing that. It just really depends on the specific example. It's not as common as you might think to give loading doses, but when you do give it, that's essentially what we're doing it for. But a lot of emergency meds, sometimes you'll do it for them. If it's something where you want immediate effect, that's where you want to do it. So that's why it tends to be more a lot of those emergency type of medications. Yep. Okay. So again, looking at this, what are some reasons we could have super therapeutic concentrations? When I say super therapeutic, what does that mean? Supra, higher than therapeutic concentrations. Why are my levels too high? Right? So looking at this, what could it be? Well, what if my dose was too high? Right? Who might that be a fault of? It could be the provider who's prescribing too large of a dose. What else? Maybe the patient takes too much on accident, right? They take a double dose, either accidentally or maybe they think, hey, a little bit's good, but a lot must be better, right? Be one way. What are some other things, right? How about the clearance? Why might clearance change on us? Kidney problems, right? They get dehydrated. Kidney function goes down. Maybe the drug itself is nephrotoxic. Who knows? Any ways to get around that? Not necessarily, right? Sometimes, but this is one of those things where some patients have been dosed on a medication for decades sometimes, and no one actually goes back through and looks at their dose to see, hey, maybe they should have readjusted based on their renal function. I had one lady, there's a drug called theophylline that we use for COPD and asthma. This lady, she was, I think, 86 years old, had been on theophylline for 30 some odd years, and no one had ever actually gone through and readjusted her dose. But again, as we said, patients get older, what happens to their kidney function? It gets worse. You have to readdress that stuff, and she ended up coming in status epilepticus, ended up dying because this theophylline level was too high for her, right? So again, you have to go back through and readdress that sort of stuff potentially. And then why might the dosing interval be off? They take it too soon, or they take double doses, say too close together, or maybe they're not taking it as frequently enough. That can actually lead to lower levels. So again, think about the ways that we can modify these and try to get around them, right? Some of them are patient issues, some of them are provider issues. It just depends on the situation. Now, looking at absorption, why might absorption be a problem for these patients here? Why might that be an issue? Well, one could be compliance. They don't take the medication. They're not going to absorb anything, right? So that could be one thing there. But also think about, if it's a complicated dosing regimen, right? If they're taking something 2 times, 3 times a day, it may be more difficult than if they're just taking it 1 time a day, okay? But also think about there could be food-drug interactions. There could be drug-drug interactions that prevent absorption of some of these medications here. So as an example, looking at something like an antibiotic, like a fluoroquinolone, like ciprofloxacin or levofloxacin, that tends to bind up calcium in the GI tract. So if I have someone who's drinking milk with their ciprofloxacin, guess what? Their infection is never going to get treated because they never absorb the drug. Right? These are things we'll talk about when we get into the actual Pharm 1 and Pharm 2 later on, these individual interactions here. But remember, this is really important education-wise, right? Let them know what they can eat, what they shouldn't eat. Take it with food, take it without food. We'll cover all of that. Remember, clearance, really dependent on end organ function, so you need to make sure you're looking at that stuff, make sure you're readjusting as time goes on, and consider making those adjustments if you need to based on continuing renal function changes or based on cardiac changes, etc. Now, looking at toxicities, we can find that the toxicities sometimes are being managed by drugs in the different tissue than what you're actually trying to treat, or maybe by in a different effector pathway, right? So for instance, when you're looking at, say, toxicity from like an opioid, opioids, we normally use them for what purposes? Usually for pain, right? Well, opioid receptors are found throughout the body, not just in the spinal column and the CNS. We actually find them out in the GI tract as well. So one of the toxicities you find with opioids is frequently constipation, right? So again, it's the same effector pathway, it's the same opioid receptors, it's just in a different tissue than what you actually intended from. On the other hand, though, sometimes you can have drugs that are causing toxicity through different mechanisms than what you might expect. So, has anyone ever heard of the drug erythromycin? It's an antibiotic. Actually, what you end up finding is it causes a lot of diarrhea. Well, the diarrhea is caused by actually working on these modulin receptors in the GI tract that causes increased peristalsis and eventually diarrhea. Now, erythromycin is normally used as what kind of drug? Anyone know? Antibiotic. So you're like, well, how does that work? Like, modulin receptors in the GI tract, bacteria don't have that. What's going on? So sometimes it's via a different mechanism, right? It's just something we happen to find that erythromycin also interacts with these modulin receptors. So again, you have to consider, okay, well, some of this can be explained by the mechanism of the drug, sometimes not, and that's it can be difficult. It's one of the things we'll learn as we go forward and look at these individual drugs. But again, looking at the reasons why we can have super therapeutic concentrations leading to toxicities here, some of them are intentional, right? So you have someone who's taking opioids. Why might they have intentional high levels? They're trying to get high, right? So again, they're using it for the euphoric purposes of the medication, or potentially they're trying to harm themselves, or potentially they're doing it because it's unintentional, right? They're trying to treat their pain that wasn't being managed effectively, and so they end up taking more, right, than they should. Sometimes that's an issue here, right? Kids get into medications all the time, right? Either stuff in the trash, or they always talk about stuff being child-proof. Is anything really child-proof? If you shake your head, yes, you don't have children. Nothing is child-proof. You can make it child-resistant. Most of the time, you just make it adult-resistant, and kids still get into it regardless. But think about things like impairment of organ function due to age, things like that. Sometimes these things are unintentional; they just happen kind of due to factors outside of our control here. But remember, anything can be poisonous, right? In the right amounts. All it determines is what the dose is where that happens at. So it's important to consider why they have these super therapeutic concentrations, what you can control for, and some things that you can't. Note here that when you're finding a substance has a toxicity, most of the time we don't have an antidote for it. Now, in the case of opioids, we have a great antidote. We can reverse those effects, no problem there. However, most of the time, we just have to give the tincture of time. What does that mean? You just have to give them time for the drug to kind of metabolize and get eliminated on its own, and so we can't really do anything to help out with that. Again, most of the time when you're having toxicities, the best thing you can do is just provide good supportive care. Obviously, stop further exposure to the substance, but give them good supportive care, and then eventually the body will take care of itself from that standpoint. Okay, so any questions on that section? Yes, ma'am.
So there's no antidote, but is there a way that you could give them something that could block maybe the receptors that are receptors that right now? Is it too late? It's already fine.
Well, in that case, that would be the antidote, right? So, for instance, with opioids, if I give naloxone, that's an antagonist that'll block the effects of opioids there, and that's the antidote essentially, right?
So, but besides like opioids, like you can't. There's not other ways to like block other applications.
Yeah, there's certain other ones, right? So again, like I mentioned, there are a few antidotes we have for certain drug classes, but for the most part, the majority of drugs, you're not going to find something quite so effective as that. Because again, most people they see an overdose or an unintentional exposure, and they're like, "What's the antidote for this?" And it's like most of the time it's like time. Like there's not a whole lot you can do for it necessarily, which is really tough because as a consultant, I get called. I'm actually on call tonight, I think. They'll call up and they'll be like, "What can we do for this patient?" I'm like, not much, but sometimes that's what you need to hear, right? You need to hear, okay, let's make sure we're supporting the blood pressure, make sure, if we need to intubate this patient, we can do that. We're supporting them until the body can process the drug and get rid of it on its own, right? So a lot of times that's some issues we run into as well. All right, so no question on that. Let's see what I can get through in the next section. This is going to be the bioavailability section. This is uploaded, correct? Please, so fantastic. Okay, so let's continue talking on here. So let's talk about adverse reactions, right? So basically, what is an adverse reaction? A reaction that's adverse, yes. Usually some sort of unpleasant, some sort of harmful reaction that is occurring here in the patient. Again, usually it's that it is resulting from an intervention of a medicinal product by the patient, right? So again, when I give you Tylenol, or let's say I give you an antibiotic and you get diarrhea, right? That's an adverse effect you're seeing from that. It's expected, but it's an adverse effect that we know about, okay? And again, if we can predict some of these, this is good because we can hopefully for future administrations either try to prevent it or maybe give a specific treatment to prevent this the adverse effect. Maybe we can alter the dose that we're giving to hopefully prevent that, maybe drop the levels down a little bit so it's not an issue, or maybe stop the product altogether, right? So in the instance we're talking about grapefruit juice in older patients and tell them to not drink it, well, if I can give a different medication, I bypass the issue altogether, right? So again, sometimes the right answer is just to change the drug altogether. Now, there's kind of 6 big categories we're going to look at in terms of adverse reactions and the different types that you run into, and we'll get into the specifics of these here. But we talk about dose-related ones, non-dose related ones, dose and time-related ones, or more chronic issues that come about with drug administration. Those are time-related, and then finally withdrawal and failure of therapy. So it's kind of this A, B, C, D, E, F mnemonic you can use to try to memorize the different categories of adverse reactions. But first off, dose-related ones, or the augmented sort of effects here, are very common, right? So you give someone too much of a medication and they get a toxicity from it. Makes perfect sense there. These are always going to be, for the most part, related to the pharmacologic actions of the drug. So for instance, if I give you, say for instance, Benadryl for your allergies, what's a common side effect of Benadryl? You get drowsiness, but you got to stay up for the next 8 hours for class. That's a problem, right? That's an adverse reaction that is expected, but now your allergy is a little bit better. Again, you take the good with the bad in some cases. Generally, these are going to be relatively low mortality, and these include most of the kind of the side effects you normally think about with medications there. But again, they're going to be very well expected here. Other things, if I give you an antihypertensive, what do you think is a common side effect of antihypertensives? Low blood pressure, right? If you get too much, you get hypotension, right? That's an expected sort of thing there. These are probably the most common ones you're going to run into. We have the non-dose related. These are going to be things that are more those idiosyncratic sort of reactions we mentioned before. Oftentimes they're unpredictable and not directly related to the action of the drug itself, which means that since we can't predict it, they're more likely to be cases where they can have higher mortality for things that we just can't know to catch there. So for instance, if you have someone who has like an allergy to penicillins, right? I can't just look at a person and know if they're going to have a reaction. They have a previous history that can help me, but I may not know that. Or anyone ever heard of malignant hyperthermia? This is really severe. If you ever hear about people having bad reactions to anesthesia, this is one of the ones that they're mentioning there, where basically patients can develop this severe hyperthermia and muscle breakdown that can occur just based off a reaction, based on a mutation to some of these general anesthetics, right? You get some inhalational gases for surgery, and all of a sudden, you're severely acidotic and hyperthermic. Again, it's something I have a hard time predicting unless I maybe have a family history that, hey, my mom had a really bad reaction to surgery. Maybe I know that they're at risk for having that reaction too. So again, hard to predict. The chronic ones, these are relatively uncommon, but these are essentially going to be patients who are on cumulative doses for a long period of time, maybe relatively high doses for a long period of time where they get some of these effects here. So as an example, going back to, you mentioned that Medrol dose pack, right? So when you are giving steroids to a person, like glucocorticoids, say for asthma or something else, your adrenal glands, do they keep producing their own steroids? Well, based off of homeostasis, you would say no, right? Because it detects that, hey, we have enough steroids around, and so I can take a vacation, I can take a little break here, right? So they stop production. What happens if I take away the steroids all of a sudden? Is the adrenal gland just going to turn right back on? No, they take time to kick back on. So for patients who are on long-term steroids, if you withdraw them too quickly, they undergo what we call adrenal insufficiency. They have issues with blood pressure, their glucose goes out of control. Like, it gets really, really difficult to manage those patients. Normally I have to give them more steroids to get them back on track. That's why those Medrol dose packs have that wean built into it, where you take 6 on the first day, 5, 4, 3, 2, 1. They'll let your adrenal glands kind of kick back on their own production, right? Now, we probably do that a little too often for most patients because they're on short-term steroids, but for long-term, this is a really big issue you run into, right? So again, this is related to the chronicity of use. If they're on it for a long time, you got to wean them off, right? Think about things like opioids. If I have a patient who's on opioids for 12 years, can I just take them off of it all of a sudden and they're good to go? No, their body has become dependent on those opioids. You have to wean them off slowly, right? So again, that can be an adverse reaction. You can see with the chronicity there. We have some ones that are just kind of time related. So again, these are uncommon and generally not related to the dose that the patient's receiving, but it only becomes really apparent after a patient's been on the dose for a really long period of time there. So a good example of this would be something like teratogenesis. Anyone know what that means? Basically birth defects that we're causing based on drug exposure. So say for instance, I have a patient who has bipolar disorder and they're taking a drug called valproic acid and they get pregnant. Now, does everyone know the second they get pregnant? Some people go almost the whole pregnancy without knowing that they're pregnant, right? Especially the first, when is, think about the first trimester being the most critical, because that's when you have all your organogenesis occurring there. A lot of patients don't know they're pregnant during that period of time. So you could have unintended drug exposure, and then guess what? 9 months later, you have a baby with a neural tube defect. I would have caught that earlier, but it's one of those things where it's not apparent at the time of taking the drug there. Another big one is something we call tardive dyskinesia. Patients with schizophrenia who are on some of the old school antipsychotic drugs, these are things that don't pop up until they've been on the drug for years and years. Not related to the dose so much, but it's just something that can happen when they've been on for a really long period of time.
That's the ones that have lithium and that cause skin problems, right?
Say it again?
Those are the drugs that have lithium in them and then that cause skin problems?
No, that's going to be more lithium itself can cause things like diabetes insipidus and whatnot, but this is more like your thorazines and things like that. If you ever watched the movie A Beautiful Mind, Russell Crowe, he's on a lot of those old school drugs, and you can actually see some of those long-term effects occur in the movie as it goes on. That's a really good example of those antipsychotic medications in action. Yeah. But yeah. So again, these are just mainly just time related, not necessarily dose related. Now, withdrawal, what do you think this occurs? 5. Withdrawal of the medication, right? So again, relatively uncommon, but it depends on the drug itself and what kind of, frequently what type of half-life it has. So I'll give you an example of this. So say, for instance, you have a patient who has depression, and they're taking medications for that. So they're on like an SSRI. Now, patients who have depression, do you think their compliance is uniformly really great, or maybe is somewhat problematic? Probably somewhat problematic, right? Sometimes their depression is not well managed. They're like, what's the point of even doing this anymore? I'm just going to stop taking my meds altogether. Well, a lot of those antidepressant medications tend to have a lot of withdrawal effects associated with them when they come off of it. You feel really miserable. You feel, it's just not fun to see, like an SSRI withdrawal for these patients here. So sometimes we can actually get around that. Sometimes I can use a drug that has, say, for instance, a really long half-life. So that way, if they stop taking it immediately, they're going to have a nice kind of self-tapering sort of dose there that lasts a long time, right? Sometimes you can't get around that necessarily, but opioid withdrawal is another good example of this. We mentioned how the beta blocker example, if you're on beta blockers chronically, you take away that all of a sudden, you have all those extra receptors that can be affected, and you have an MI that can be induced there. So these are really adverse effects that occur by sudden discontinuation of the drug. Okay. Now, how do you think you would treat that? Yeah, so you either give the drug back, right, to prevent the withdrawal symptoms, and then you could taper off slowly. That's really the big thing there. And then you can have failure of therapy. Now again, a lot of this could be relatively common, could be dose related. Maybe I'm not giving a big enough dose, or it could be really due to drug interactions. I mentioned that example of calcium in milk binding up to, say, antibiotics in the GI tract, and that is a failure of therapy. The bacteria is still there because they never got exposed to the drug in the first place, right? Or potentially, for instance, oral contraceptives, right? Usually oral contraceptives are based on what type of hormones? Estrogen and progestins, right? So progesterone and estrogens there. What could happen if, say, for instance, someone's on an enzyme inducer, some upregulating hepatic enzymes? What do you think I would do to my estrogen progesterone levels? So I have more enzymes around to metabolize the drug, so levels of the drug would go down. And so how do you think that may manifest? Pregnancy, right? That's probably one of the most significant adverse effects I can think of. It's a lifelong adverse effect that you're going to be dealing with for at least 18 years, right? So these are things you have to consider, right? So again, that's an example of where the dose, even though the patient may have been taking an appropriate dose, because the body was metabolizing more quickly, it was not appropriate for them at that point, right? So this is why drug interactions are so important to identify. Now, you may hear people talk about adverse effects versus side effects. Typically, side effects are kind of more undesirable, but usually they're going to be more of a nuisance than anything else. You may hear a lot of people use the terms interchangeably here. Normally, I think about like adverse reactions being typically a little bit more severe, and I'll give you some examples of what that looks like. But again, sometimes side effects can be a good thing. So I mentioned latisse being used for glaucoma. It lowers intraocular pressure. It's great if you have that, but also we found that as a side effect, it caused your lashes to become longer, right? So now what do we use latisse for? For its more aesthetic purposes, right? So we use it so you have nice long lashes. However, another side effect is it can actually turn your irises brown. So if you have nice baby blue eyes, that may be something you may want to weigh into your consideration. Do I want to still use this drug or not if it's going to turn my iris brown? It is, yes. Yeah, so we'll still use, and again, like you have to think about how it's actually being applied because the latisse is actually to the lashes itself. You may still have some contact, but the actual glaucoma med is actually instilled into the eye itself. Yep. So other things you can consider as well. So for instance, there's an antibiotic called Bactrim, which is a combination product of two drugs, sulfamethoxazole and another one called trimethoprim, used very frequently for all kinds of things, UTIs, skin infections, etc. Something like a side effect might be considering, rash and urticaria in, say, sun-exposed areas. We call that photosensitivity. Well, that's something you can deal with, right? You can say, hey, make sure you stay out of the sun. Make sure you put on extra sunblock, something like that, an actual physical blocker, sunblock kind of product, versus something like an adverse reaction like Stevens-Johnson syndrome. This is a very severe skin manifestation, skin toxicity that occurs. Again, it's rare, but it is almost devastating and can be fatal if not treated early, right? So this is why you educate patients, like, hey, yeah, stay out of the sun, but also if you start to notice any blistering, you start to notice any kind of like, sores in your mouth, you start to notice any kind of skin coming off, that's a really bad sign. You go to the ER right now, right? So again, these are things to consider, and you'll learn about these, both the minor nuisances, the minor side effects, and also the more serious things you want to watch out for as we get into the specific drugs. Other things to consider, things like Viagra, right? We mentioned Viagra is being used for what indication? Erectile dysfunction, right? So again, a side effect may be an upset stomach, right? Causes smooth muscle relaxation. That can happen on the esophagus as well, and you get GERD symptoms. Okay, that's I can deal with that. I can give them some Zantac or something and deal with that. However, if they have sudden loss of vision, that sounds pretty bad, right? So again, these are things that you have to know what the really bad stuff is. It might be rare, educate on that, but also the more common things you're going to run into, right? Or for instance, lisinopril, which is an ACE inhibitor that we use for hypertension. A side effect could be cough, something due to buildup of a product called bradykinin, versus angioedema. Imagine you see a patient come in with a tongue swollen like that. What do you worry about? Yeah, blocking the airway, right? So that's a patient needs to be intubated right this second. Otherwise, they may lose that airway, and that's no good. Yes, ma'am.
So like with the loss of vision, do you get that back or no?
Depends.
Okay.
Yeah, sometimes not. But it's rare, right? So it's, again, I don't know if you guys ever heard the mantra, but there's killers, commons, and zebras, right? So you want to think about this when you're developing like your differential diagnoses for things. You want to think about the common things that happen, right? These are kind of the normal side effects you run into. Cough with the ACE inhibitor, right? You want to think about the killers, things like the angioedema that can potentially be really deadly, and then the zebras. You know what I mean by zebras? Kind of rare stuff, a really kind of oddball, kind of rare stuff you have to kind of consider. It's not common, but again, you want to be at least cognizant of them when they do pop up. So if it does happen, you'd be like, oh yeah, I remember hearing about that one time in pharm class that many years ago. Here it is, right? That does actually happen. So again, kind of think about the killers, the commons, and the zebras there. So getting into that, so kind of moving from the adverse effects and side effects and whatnot, talking about adverse reactions, right? Why do we have adverse drug reactions in patients? And again, this is specifically in terms of medical errors, right? Because are medical errors really common? They are exceedingly common. You will probably make a medical error at some point in your career. You'll probably make a lot of them, actually. People make errors all the time. Do all errors end up in patient harm? No, very few of them actually do. Some of them actually do lead to harm. Have you guys ever heard of the Swiss cheese model? You know what that means? Basically, every person that works in the healthcare environment is a piece of Swiss cheese, right? So Swiss cheese normally has what in it? It has holes, right? So presumably you as a provider, if you're writing for a medication there and you make a mistake, you write for the wrong dose for a patient, it comes to the pharmacist. So the error got through your whole Swiss cheese. Presumably, I'm going to be the one to catch it, right? Am I always going to catch your errors? I would like to think I would. I might not, right? So I might miss it. Now, again, I might be working with you guys one day. I work with a lot of people that have graduated over at Nemours all the time. I call them up and I say, what are you doing? I taught you better than that. But let's say, for instance, I didn't catch it. Now it's gone through my whole Swiss cheese. Now, who's the next person that might interact with that? Well, it might be the nurse who's going to give the medication. Is she going to catch it? Hopefully, right? That's the answer is always hopefully, but she might not. And then all of a sudden now all the holes of Swiss cheese have lined up to now the patient gets that medication error. Okay. So again, it's an important concept to get. It's like there's a lot of steps along the way, and when you do find the errors that have occurred, there's usually a lot of people have actually had their hands on those orders at some point. And so that's why it's always considered it's really important to make sure you're always thinking about the 5 rights, right? The rights of getting the right medications to these patients here. Okay. So when I mention it, I usually mention the right drug, the right patient, the right dose, the right route, and the right time. And I'll give you some examples of how this can come up in clinical cases. So the right drug, right? Is it easy to always get the right drug? Not necessarily, right? So for instance, imagine if I accidentally misdiagnose someone with not me, but say you accidentally misdiagnose someone with a bacterial illness when it was really viral, and I give them antibiotics. Is that right for them? Nope, because done pretty frequently, in fact. But again, it's harder than you think. So imagine, there's a lot of drugs that have misleading names on them, like so there's SR formulations, XR formulations. If you goof that up, you may be dosing the drug inappropriately, right? If you have a patient comes in and say, oh yeah, I took Tylenol. What does Tylenol mean? You assume it's acetaminophen, but Tylenol puts their name on everything, right? So it could have been Tylenol Benadryl, it could have been aspirin-containing product, it could be a lot of different things. You have to always consider, okay, what else could this actually be here? And then, being in Orlando, you get a lot of people from different countries coming in, right? So I get a lot of medication bottles that have come from, say, South America. And I have to figure out, okay, well, are they from Brazil or are they from Ecuador? And then, okay, do I need to translate this from Portuguese or Spanish? What is it, right? So I got to figure that out. As an example, albuterol, which is a typical, asthma medication that we would give for patients. If they're coming from the UK, they call it salbutamol. But if you don't know that, you don't know what drug they're talking about, right? Or how about acetaminophen over in the UK is called paracetamol. Now, how would I figure this stuff out if I need to translate some of this? Now I do it. Go to google.com and I type it in and I get a translation, right? It actually works 9 times out of 10. You're going to find the right information there. But that's important because, again, if I misidentify what these drugs are or something like that, you can make a really big error. Because some of these kids, come in from Make-A-Wish trips to Disney and stuff, they have a lot of medical issues and a lot of drugs are on. If we goof something up, it can be really deleterious to them. Now, getting the right patient. Now, is it hard to give the drug to the right patient? Could be harder than you might think, right? So things like name alerts, right? We have a lot of patients who have very similar names, especially like in high flow areas like the ER, right? You have patients coming in and out all day long. You could have 3 Smiths in 3 different rooms at a time. You could have 4 Rodriguez's. You could have 5 Joneses. You find that people have very similar names, and it can be difficult to make sure you're getting the right patient there, right? Or how about siblings? I will tell you that we have twins that get born and get sent over to the NICU at Nemours all the time. You know how they show up in the system? Baby A and baby B, and they'll put them in the same room. And they'll put in, say they're in 314. It'll be 314A and 314B, so that way they can be in the same room together. So you think, okay, well, baby A should go into bed A, right? Nope, they'll put baby A into bed B and baby B into bed A. So what are you doing, right? Well, how do we get around this sort of thing? Well, this is where we have things like barcode scanning, right? So we have now technology that can help us out to actually make sure we're getting the right patient there because they'll have a unique identifier. Nurses scan it, and they'll scan their med, and everything should be good to go, right? However, I'll tell you, I get calls all the time from nurses. They're like, oh, yeah, I gave the med to the patient, and then I scanned it afterwards, and it came up wrong. Maybe you should have scanned it first like you're supposed to. Oh, no, I was in a rush, but, what do I do? I don't know. Let's document our medical error, I guess, now that we have. But other things as well, patients move rooms all the time. Hey, give it to the patient in bed 3. Well, an hour ago, that could have been 3 different patients. Like, you have no idea. So, again, it's very important that we make sure we're keeping the right names in mind, make sure we're giving it to the right patient. That can be really, really difficult in some cases. How about the right dose, right? So ensuring we're giving the right dose depending on their age, gender, organ function. That's super important here. And again, think about the doing home medication reconciliation. Now, a patient comes into the ER, you have to do a med rec. Who do you think is doing that medication reconciliation? Usually the nurse is doing it. Some places it might be like a pharmacy technician or something, but usually the nurse is doing it, and they just say, okay, what meds are you taking? They just type it in, and it's done. The reason why that matters to you as a provider is because when you're reviewing that list, you're hoping or you're assuming that's going to be correct, right? Especially if you're admitting the patient and you're trying to say, do I want to restart or not these medications? You assume that list is correct, which may or may not be true. So I'll give you an example. We had there's a patient over at in ORMC, and they were coming in. They were taking methadone. And so the technician asked him, at a pharmacy tech doing this, say, hey, what dose of methadone do you take? And the guy's like, I'm going to take, 60 milligrams twice a day or something. It was a pretty high dose, but not something unheard of for a patient on methadone, right? And so they went back to the pharmacist. The pharmacist says, yeah, it looks good, whatever. And then the patient got admitted. The doc said, okay, this looks good, ordered it. Guess what they found the next morning? The patient was near comatose in their bed. Guess what? The patient lied about the dose they were taking. No one bothered to do the double check to see is that true or not. And the patient got overdosed. And they gave him Narcan, reversed him out of it, and he was okay. It was one of those things where you had to be really, really careful. Sometimes patients will lie to you on purpose, right? I know it's hard to believe, but they will do that. So always consider these things. How about the right route of medication? You'd like to think that the right route would always be assured here, but there are cases where things can be fatal if given via the wrong route. So I'll tell you, for instance, there's some chemotherapy drugs. Say, for instance, I have a kid who's got leukemia, and they're getting IV medication and intrathecal medication. We have to make sure we give the right one via the right route. Otherwise, if we screw that up, guess what? There's one called vincristine. If I give that intrathecally, it is fatal to that patient. Okay? So we put things in place to make sure we don't do that. So, for instance, intrathecal medications come in a syringe. We make sure we never put vincristine in a syringe. It always comes in a bag, right? So the things we try to do to prevent that. But again, when you see like big errors like this, you see big warnings. Why do you see big warnings like that? probably because someone's done it in the past, right? And someone's probably screwed this up. That's why they make such a big deal out of it. Also consider, like, sometimes meds are just given via non-traditional routes. Like we have a drug called Docusate, which is a laxative. Well, I can actually put that in the ear, and I can actually have to break up some of the earwax and can help with patients who have an impaction. It's weird, but something that is done occasionally. So sometimes things that look unorthodox are correct. Okay, sometimes meds given via the wrong route, like for instance, vitamin K can actually cause hematomas potentially. So we don't like to give it that route. Sometimes sub-Q is better. IV might be better. So again, these are things you'll learn as you learn about the medications. And then timing can be really important as well. So making sure that medications are not given too soon together, because you can see more toxicity. Making sure they're not being taken too far apart, because you can run into some issues with that as well. So for instance, thinking about things like emergency contraception, right? So someone, say, decides they want to get Plan B, right? Now, there's a certain time frame with that, right? If they go 2 weeks after that intercourse, the drug's not going to be all that effective, right? So at the wrong time, right? They need to take it within 72 hours or so. Or perhaps if we're giving, say, antibiotics too infrequently. They're supposed to take it twice a day, but they're only taking maybe once a day. That could lead to bacteria still repopulating, and thus it's not going to work very well. So again, timing can be really important. That's why we have to consider what the dosing interval is, make sure they're adhering to that. Okay, so I think I'm going to check the board, see if there's any questions there. Is there any questions before I wrap up? So this will be the end of the material for the test. Not this slide, but every slide before this, right? So go over the pharmacokinetics block. The majority of the questions will come from there, and then you'll have part about adverse reactions and whatnot here. Okay, medication errors. Any other questions before I check the sticky board? Yes, sir.
Is the test to contain information from the first 2 weeks at all?
No, it'll be just self-contained to the pharmacokinetics section, so lecture 3 and whatever we covered today. The final, though, is going to be over everything, right? So it'll be another 25 question test. It'll be the same format. I'll probably have Naz or someone proctor. I probably won't be here for that first part. And then I'll come in and we'll do the rest of the lectures there. But looking at this, okay, is steady state essentially the place where we get most effectiveness out of a drug? Yes, the patient should be at steady state most of the time that they're on the medication, such that that is their average concentration. That's just where they're at. And so again, by modifying it, that's where you can say, okay, well, I'm going to jump this average concentration up to be more effective, or I can drop it down because they're getting toxicity. I need to get to a lower level, right? So again, that's just the average of where they should be at if they're taking it consistently. Okay. Any other questions? Yes, ma'am.
Can a side effect be a dose-related adverse reaction?
Can a side effect be a dose-related adverse reaction? Yes. So sometimes, say for instance, like that Benadryl example, you get sedation from that. If I take more Benadryl, you might get more sedate from it. So it could be dose-related for sure.
Okay. So side effects overall can be an adverse reaction.
Yeah, again, sometimes you'll hear it kind of interchangeably, but in my mind, I like to think of side effects as kind of being more the nuisance sort of reactions that are not really medically necessary for an intervention. Adverse effects tend to be more severe sort of reactions for the most part. Okay, anything else? If not, I will see you guys next week.